So the registry is looking at men with metastatic castrate-refractory prostate cancer. So that's basically, prostate cancer is a disease that responds to lowering of testosterone. So the initial treatment is lowering of testosterone to castrate levels or medical castration. And this is looking at men beyond that, so who have castrate-refractory disease. And this is an important unmet area of medical need, but an area that's changed rapidly in the last sort of 5 to 10 years with the introduction of 5 new therapies, so abiraterone, enzalutamide, docetaxel, cabazitaxel, and radium-223, as well as supportive medicines such as zoledronic acid and denosumab. So an area of real change. So the motivation behind the registry was to really see how those new treatments were being introduced in a real-world setting, to see about sequence, to see efficacy of those treatments, and I suppose see access to them as well. So an important area of medicine that's changing rapidly, and to get a real snapshot. The registry is 3,000 men who will be followed for a maximum of 3 years, so it'll give us a real insight, and the depth of data is actually very impressive, so with quality of life data as well as efficacy data, comorbidities. And we're seeing within that a patient population that the clinical trials were very, very good clinical trials, but there was always an element of selection. I mean, we're a big clinical trial centre, and not everyone goes into those, whereas with the registry, we've also been a centre for the registry, all our patients will go into that. So the bar is lower, and so you tend to see more of what you actually see in the clinic. So those have been sort of the main bits behind the registry and the motivation going forward. Yeah, so it's still pretty early. So it's looking at we're looking at patients who had a minimum of 12 months follow-up, and that's almost 2,000 patients. But 12 months is still slightly early in the course for these patients. But we'd seen a lot of patients having drugs like abiraterone and enzalutamide. So these are drugs that, in my opinion, have made the biggest difference for this group of castrate-refractory prostate cancer patients. So it's looking at where they were used. And in this group, we divide them into patients who've had chemotherapy and who haven't, so pre and post chemotherapy. The bulk were pre-chemotherapy, and we could see very good activity for both drugs, slightly more for abiraterone, and then the post-chemotherapy lower activities, which we expect from the key studies. It sort of tells us that we're capturing what we'd expect from the treatments, but also seeing the efficacy we'd expect. So it's quite a good sense check. So I think those are the sort of the top line data where that's concerned, and then looking at things such as the number of patients over 70, the demographics, a lot of patients over 75, a lot of patients with comorbidities. So really seeing what we see in our own clinics. So that's sort of what I got most from this bit of data. But the data is going to evolve nicely. I mean, the good thing about something like this is it gets more interesting each data snap that we look at, because we capture more patients and patients who've been followed for longer. And one of the big things when you introduce several new treatments is about sequence and access. So how are people using these drugs? Are they using them sequentially? Do people have access to all or some of these therapies? Does that appear to be affecting outcome data, toxicity, etc.? So I think it's something that's going to get more and more interesting as time goes on. I suppose I was slightly surprised at the dropout rate, just because patients who'd been lost to follow-up, or patients who, I think some patients who died, that isn't our experience of our own centre. But I think, again, it probably represents a real-world centres in that we're not going to typical clinical trial centres. We're going to centres that perhaps couldn't contribute in the landmark studies, because if you're introducing a new investigational drug, that takes a lot of research capacity. So in some ways it sort of backs that up. I was slightly disappointed with that, but I think that probably feeds into the centres we're looking at, and the fact that I think the data will actually reflect what's happening in the community as well as academic centres. No, it recruited really well, actually. I mean, it almost recruited a bit too quickly. I mean, we've recruited 3,000 patients ahead of time. Most of those patients stay on study, so no, recruitment wasn't a challenge, actually. I think people were really engaged with this idea of actually, I think we all have a sense of what we think is going on there, myself very much included, and it's quite nice to actually put it down and find out what's really happening. We all think things work better than they necessarily do, because you remember the patients that come back, you have positive reinforcement, you forget the patients to a degree who don't do so well. And I think a study like this actually, you know, in black and white says, well, actually, this is how your patients did do. This is how long they were on drugs. This is the side effects they had, etc. Has a real value. Yeah, I think it's probably a bit early for that. What I would hope is that it will show that patients who have access to these new therapies do better, that they are manageable within both academic and non-academic centres. I think those are probably the main, and also for the patients who aren't reflected that well in clinical trials, as I said, patients with more comorbidities, slightly older patients, that they can be managed very successfully with these drugs. I mean, the drugs on the whole are not that difficult to give, in my opinion, but you need the support with it. And I suppose it's about people getting confidence. I would hope this will reflect some change in patterns of care and show that, and give people confidence to use the drugs and to use them sequentially. I think the main bit will be looking at getting more patients being followed for longer and looking at the data of sequence. I think everyone's interested in sequencing of these drugs and who's having access to what, and does that make a real impact on definite disease outcomes. The next time we're meeting, I think we've got a formal meeting early next year, so I think we'd hopefully have some data either for the European Association of Urology meeting or for the main American Society of Clinical Oncology meeting. That's my understanding. I think we've got an informal meeting towards the end of the year. So, but it's just great, because having set this up, and most of the work has not been done by myself, far from. It's been done by lots of people within Janssen and lots of investigators and research teams. But it's very nice to sit down and you see suddenly the data maturing, and sort of what was quite a sort of abstract concept, and you thought, really, will people follow patients up like that? Will they fill in, you know, quite extensive quality of life questionnaires, etc. It's been pretty good, to be honest. So it's exciting to see that develop, and then sort of seeing why is that happening, and going back and looking at what was happening in that particular patient group, and did patients who had, say, primary surgery do differently from patients who developed had metastatic disease at presentation. So lots of really interesting questions. Oh, I think similar to that, really. I think it's very much as the data matures, you get that sense of what goes on. I think also for me, I work in a big London teaching hospital. I'm very fortunate that we have access to drugs, we have access to clinical trials, we've got a big research team, we've got quite a lot of philanthropy. So our practice doesn't represent what's norm both within the UK and beyond. So what's been very instructive for me is to see what's happening, say, in France, or even within England and Scotland. So I think that's the bit that is quite useful for me, just to see what are the practices across Europe as well as within the UK itself. And then looking at those things, again, saying you can get misled by your own personal experience, because you have, I think oncologists are by nature optimistic, and therefore it's quite good to have a sense check sometimes of maybe, you know, it isn't right to use these drugs in this particular order, or it raises a question that you then have to take forward in a sort of a prospective clinical trial. But I think all of those things will be important going forward. Yeah, I mean, I think from the patient perspective, several new treatments coming through, and it's going to show patients in several different countries what access is like, and does that access affect outcomes. So that's a primary goal for patients and their families. I think also it's a good educational piece, it raises awareness of other treatments, and it shows that you don't have to be working in a big centre to give these treatments. So I think from a patient perspective, quite a lot of education about what's out there, and that by using these drugs, patients, in my opinion, will do better. But as I said, we need to see the data and confirm that.